Hello, my name is Gemma Crawley and I am the Senior Asthma Educator for Asthma Australia. There has been some changes to the way that asthma is managed in Australia. There were some changes that came out in the Australian Asthma Handbook, which is the guideline for treating asthma in public health, which is in the GP practice and with specialists as well. And that happened at the end of last year. So we're going to go through what some of those changes were. There are quite a lot of changes, so I'm just going to focus on one of them today, because otherwise we'll be here for quite a long time, and it's easier if we just go through one of the changes, and then I'll do another Facebook Live in the next couple of weeks. So asthma, as you are aware, because the people that tune in for these things generally have asthma, is really quite complex, and everybody's asthma is a little bit different. So some people have asthma every day, and it doesn't matter how much medication they take to try and prevent it, they still get symptoms. And then there's people that have symptoms maybe every few months just with a virus. There's people that get seasonal asthma, where they only get symptoms in spring when the pollen comes out, or in winter when there's viruses and colds about, or both. So everyone's a bit different on how they have asthma. Some people are very, very mild with how they have asthma. They might only get asthma when they exercise, and that's it. They don't get asthma any other time, only when they exercise. They might only get asthma once a year with a very, very bad chest infection, and that's it. They don't get asthma any other time of the year. So for 12 months in the year, they don't get asthma at all. No problems, no symptoms, no other triggers, nothing at all. And they don't need to treat their asthma other than that. And a doctor would be looking at that frequency of symptoms, and they'd be looking at the severity of those symptoms, and they would be saying, that's classified maybe as mild asthma. And then someone who has symptoms every few months, or every month, or every week, and that needs to, and is taking a blue reliever every couple of weeks or every week, or they're taking it more than twice a week, which means that they've got inflammation in their airways and they're triggered by things more than the person that has the mild asthma, we might call that moderate. So they're more inflamed, so they're more severe than the mild person. They have more frequency of symptoms, and they are taking more Ventolin, or more salbutamol, more Asthma, more Brecanol, more blue reliever than the other person. So they're moderate. So they're on a different treatment regime, and then it goes up. So think of asthma as it's like every other health condition. There's people that have very mild symptoms of a health condition, then there's people that are in the moderate range of a health condition, and then there's people with severe end of the health condition, and it's exactly the same with asthma. So what the experts have been doing globally is looking at how we treat asthma. Now, historically, all of the health professionals have been treating the mild asthma group with blue reliever, basically. When it's just we've got symptoms very, very occasionally, you know, so we've just got symptoms once in a blue moon. Okay, so we're just talking about on exercise only, or we're talking about we've only got symptoms that once a year, you know, so we're not having symptoms 1 or 2 times a month. We're not having symptoms every couple of weeks. We're not having symptoms every week. Okay, so we're talking about the really infrequent group of people taking blue reliever. So they're the mild group. Okay, so we've been treating those people with blue relieving medications. But we're sort of the global specialists and the global researchers have gone, there's still inflammation in the airway, because asthma is a condition of inflammation. So if we go back to the basics of asthma, and if my fantastic team could put up a picture in the text here of a normal airway and an asthma airway. A normal airway is open and it's pink and you can easily breathe through it. Okay, so if we think of a pipe, it's very open, there's no, you know, we can see down it, there's no tightness, it's all happy, you know, we can have a party in there, you know, have a little dance in there, it's all good, everything's fine. But in an asthma airway, it's red, it's angry, it's sensitive, and then there's rings of muscle around the outside of the airway. And then as soon as we breathe in some air, that those airways that are sensitive don't like those rings of muscle go, nyeh, because they're trying to protect those sensitive airways. And then that's just not helpful. Well, they think they're being helpful because they're protecting themselves, but then we can't breathe. So all of these very, very intelligent people out in the global community have gone, if we're just using blue medication, we're not treating inflammation, because the blue medication, so salbutamol and terbutaline, they're the blue medications, they're the drug names for the blue medications, they only work on the muscles around the outside of the airway. They do nothing for the inflammation on the inside. I'm just going to scroll up. No, we don't have our pictures. Okay, all right. So I'm going to be very, very technological here and show you pictures. Can you see my pictures? Right, so you can see the muscle rings around the outside of the airway. So that's the normal airway, and this is the not happy airway. And we can see that's swollen and it's not happy and it's got mucus, and we can see that the muscles are squeezing tight. So the blue medication that only works on the muscles, only works on the muscles. So we're not actually doing anything about treating this stuff in here. It doesn't treat that. And that's what all of these very smart people around the world are worried about. Because if we don't treat the inflammation and the sensitivity on the inside of the airway, then we're not actually treating the underlying causes of asthma. So it's like putting a Band-Aid on asthma. It's like saying to someone who has high blood pressure, here, have a Band-Aid. It's going to do nothing for their blood pressure. So it's doing nothing for our asthma. So what the global group for asthma suggested was that we start treating mild asthma very differently. So then the recommendations from the global group has then filtered to all the different countries, and Australia has taken that on board. So the Australian body who sorts out the guidelines for primary practice, so that's the GPs and specialists, etc., etc., is the National Asthma Council, so the NAC, National Asthma Council, and the guidelines, as I said before, is the Australian Asthma Handbook. And in those guidelines, there's now a bit of a change on how we treat mild asthma. So we can treat it in 3 different ways. We could treat it before in 2 different ways, and now we can treat it in 3 different ways. So we used to be able to treat it with just the blue reliever and then say, what are we going to do about the inflammation? We'll just let it sit there and grumble along like a big iceberg. And the problem with that being is that if we don't treat the underlying inflammation, then when someone does have a flare-up with their asthma, it's usually big, it's usually nasty, and it usually involves a hospitalisation. So, because the inflammation is just grumbling along underneath. Particularly if there's a virus involved, because when you have a viral trigger, well, a virus is going to cause some inflammation as well. So it's just going to go and just, set off this nice, huge asthma flare-up. The other way we could treat mild asthma was to have the blue relieving puffers if we needed to treat the symptoms. So the symptoms of asthma. So if we think of an iceberg, so we've got the inflammation underneath. We've got the inflammation underneath the ocean, like an iceberg. And then the tip of the iceberg is just what we see on the outside of the ocean. So that's the symptoms that we see are the wheezing and then the cough and the chest tightness, which sometimes isn't even tightness, it can be like a heavy sort of kind of like feeling on our chest. And with kids, that can just be a soreness, they can rub it, or it can be a sore tummy, because kids can't tell you that they've got a sore anything, everything's a sore tummy, so sore tummy, and shortness of breath. Okay, so if we're feeling a little bit puffier than normal, okay, so there are symptoms. With kids, we get recession here, that gets pulled in, the ribs, the skin around the ribs gets pulled in, and they can get tummy pumping as well. So their tummies are pumping in and out because they have an increased work of breathing. So they're using all of their muscles in order to breathe. So, so that's what we're treating with the blue reliever puffers. Okay, so the salbutamol and the terbutaline, so that's Ventolin and Asthmol and Bricanol. And I should say that in Asthmol, Bricanol and Ventolin in that order. So we could treat just with those medications and leave the inflammation, or we could treat it with those, with the blue relievers as well, and then a preventer. Now the preventers are your autumn coloured type medications. So the autumn coloured medications, if I bring up a picture for you, unless my cool friends in the technology department are able to pick up a picture for me. Have I got a picture of all the different? So some of the preventers, right, so there's the blue ones, but we've got sort of autumn coloured looking ones there. And then we've got some of these ones too, which are combination ones, and I'll go into that in a section in a second. So the preventers have a steroid in them, and it's the steroid in them, an inhaled corticosteroid. And when we say steroid, we don't mean like, heaps and heaps of steroid, bad. I'm talking about a teensy, tiny little dose of steroid that gets inhaled right down into the good parts of our lungs where we're going, where it's needed, okay? We're not swallowing it into a into our stomachs, okay? Jay, I'll sort out questions later. Just let me finish my spiel on what I'm talking about, and then I'll do questions later. Now the preventers and the inhaled corticosteroids, they work on the sensitivity and the inflammation on the inside of the airway. That's their job. and they control that sensitivity. So now we are treating asthma. We're looking after that airway, and we're reducing the inflammation, reducing all of that sensitivity, so we go back to having a normal looking airway. So it's open and happy, and we can have a dance in that airway, okay? So when we breathe in a trigger, whether it's, you know, pollen, whether it's cigarette smoke because we've walked past someone who's smoking, whether it's dust in the house, whether we're cleaning the loo and we smell whatever cleaning product we smell, then the airways don't tighten when we breathe in that particular scent or trigger, okay? When we go to the gym and we're exercising, we don't then have such a, you know, reaction to the exercise as well. So that is how the relievers work, and that's how the preventers work. Now the combination preventers are pretty cool. They have two medications in them. They have a long-acting reliever in them, and they have a preventer as well. So they've got the inhaled corticosteroid, which is working as the preventer to reduce the inflammation and sensitivity, mucus production, all the rest of it in the airway. But they also have a long-acting reliever, which is different to the blue relievers, that works for 12 hours. So it works on the muscles to reduce that tension in the muscles around the airways. So the technical term is bronchoconstriction. Broncho meaning the airway, constriction meaning tightness. So it reduces that constriction, that bronchoconstriction, that lung tightness over a 12 to 24 hour period, depending on the combination that you've got. So some of them are 12 hours and some of them are 24 hours, depending on which one you prescribed. So we've got relievers, we've got preventers, which just have inhaled corticosteroids only, and now we've got combination preventers, which are both. They've got the reliever in a long-acting reliever in them, and then they've got the combination preventer what did I just say? It has a long-acting reliever, and it has the inhaled corticosteroid in there as well. With the combination preventers, you would normally be on a blue reliever as well, because you need something that's quick acting, because when you're wheezy or coughing or, you know, have symptoms, shortness of breath, chest tightness, you need something to quick acting relieve those symptoms. Now, this is where the change comes in. There is a new way of using two of the combination preventers. Now, one of them has been used in this way before as a maintenance and reliever therapy. So one of these particular medications has a drug in there called budesonide and formoterol. So I'm using technical words here, I know that's really mean. So it's called budesonide and formoterol. The brand names are called Duroresp, Spiromax and Symbicort. Now, to make that a little bit easier, we've come up with a name that is dual purpose reliever. I think that's a little bit easier, don't you? So it's a dual purpose reliever because, like a combination preventer, it has a dual purpose and it's a reliever. So these two particular medications have been used as a combination preventer in the past. So they've been used safely in asthma management for many, 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 many years. But unlike some of the other combination preventers, they actually have, oh yes, Kylie, I do think it's a good name too, because I think it explains what it's supposed to be doing. There's two medications, it's dual, and you know, it's for a particular purpose and it's a reliever. So these particular medications, as I said, have been used for many, many, many years. So we know that they work, and we know that they're safe, you know, so they're not new to the market or anything like that. Just the way that we're using them is a little bit different. So the reason that they're different to their other counterparts is the long-acting reliever in there works for 12 hours, but it has a quick onset like the blue relievers. So the blue relievers work within 4 minutes. So Asmol, Bricanol, Ventolin, they work within 3 to 4 minutes to give you that relief. Now, some people find they even work even faster for them. But if we go by manufacturers, they're supposed to work within the, 3 minutes. These medications, these dual purpose relievers, also work within 3 to 4 minutes. So that means they can be used as a reliever, just like the blue ones. But because they've got an inhaled corticosteroid in them, not only are we giving ourselves a relieving dose of medication, but we're also getting some of the steroid, the inhaled corticosteroid, to manage the inflammation in our airway. It's pretty smart, huh? So it's far more protective of our airways than being on just blue reliever by itself. So if we're looking at the guidelines now with the 3 different ways to manage mild asthma, and so I'm only looking at the milds, okay? Only mild asthma. So we're looking at the grouping of patients that do not have symptoms very often. And if you're not sure if you fit this grouping, that's okay. What you need to do is start writing it down. Keep a symptom diary for a week or 2, and then pop to the doctor and say, Asthma Australia have talked about this new medication, or this new way of using an old medication. It's in the Australian Asthma Handbook, Doc. Would I be suitable for it? If you are on a blue relieving medication with a preventer in the morning and at the night time, but your asthma is not well controlled at the moment, then probably not, because you're already on preventer morning and night and you've still got asthma symptoms. So I would, that would indicate, if you've still got poor asthma control, that this particular type of treatment is not the type of treatment for you, because you're already on morning and night treatment, and this would be a step down in treatment for you, which means it would be less inhaled corticosteroid for you, which means then it wouldn't control asthma enough for you, if that makes sense. So we're talking to the people at the moment who are using blue reliever only. So if you're only using a blue reliever puffer, or you're on a blue reliever puffer if you're on a blue reliever puffer and you're taking preventer medication morning and night time, and you've had no asthma symptoms, none, absolutely none, for the last 3 months. So according to the Australian Asthma Handbook, if you have had no asthma symptoms for a 3-month period, then you can have a discussion with your doctor about stepping down preventer treatment. And you only step down by 1 step. So that means if you're on a higher dose of preventer, then you can drop down to a lower dose. So that means if you're on 2 puffs of something, say, I'll just pick something out of my head. Say you're on 250 of something, and there is a 125 dose of the same thing, like the same brand, then they would drop you down to the 125. They wouldn't drop you down to this kind of thing. Okay, so you would drop down and make sure they wouldn't drop you down very quickly. Okie dokie. But it might be something that you could get dropped down to over time. So we're talking to the mild people. So if you're on blue puffer only, or you're on a low dose, so you're not taking much preventive medication morning and night time, and you've had very, 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 very good asthma control in the last 2 to 3 months, preferably 3, but even if you're skating in on the 2, have a talk to doctor, because maybe you could start the conversation with doctor and then see how you go over this last month, and then they can do, if they're not too sure about the therapy, then they can do a bit of reading before you go down on dosage, because as I said, it's new in the last year, so doctor might be not completely au fait with it yet, or up to date with it yet, so they may need to do a little bit of reading, and then have a discussion about whether or not it suits you. So you don't have to make a decision or anything like that. Have a discussion with doctor first, but do a symptom diary, because that can be really helpful. Now the other thing to think about also is the Duro-Resp brand is, so it's budesonide and formoterol in the Duro-Resp manufacturer's brand is for 18 plus only. The Symbicort brand in a Turbohaler or a Respimat is 12 plus. So adolescents 12 plus can go on to, they have mild asthma, so not having symptoms very often could be considered to go on to this particular treatment. So have a chat to your child's doctor if you think that they might fit into this cohort. So only having asthma once a year with a virus, etc., etc. Now, if going on to this particular type of treatment and it's a change to your asthma management, we need a new written asthma action plan. So, pulling out your written asthma action plan. So I know this is probably backwards for you guys, but if my team could, put a link into the feed, please. The more robust your written asthma action plan is, the longer your doctor goes through and writes instructions, the more instructions there are there for you, the better it is that you can treat and manage at home and not have to have a very severe flare-up in the home environment, and then you can manage better with your GP. So it's extremely important to have a written asthma action plan. Everyone, children and adults, need a written asthma action plan. We get a lot of questions on the helpline about, oh, I was told I don't need one because I'm an adult. Phooey. Everyone needs a written asthma action plan. So in these, I know you can't read it because it's going to be back to front, but I'll just show. There's a section here that says well controlled, and that's where doctor writes what you're normally taking morning and night time, if you're taking something morning and night time, and what you're taking as required. So in this particular therapy, if we're talking about the new one, then it would be the dual purpose reliever medication as required. So I'd be taking like the blue puffer, but we put the blue puffer to bed now, we put it in the drawer, and we would carry the dual purpose reliever medication in our pocket and just whip that out every time that we would need it and get short of breath or have wheeziness or cough. And then that would be written in our well control section. And then in the next bit it says flare up. And when I've got a flare up, I'm having symptoms more than twice in 1 week. So I've had my wheezy cough or a wheeze or chest tightness or shortness of breath more than twice in 1 week. I've had symptoms on activity. I've been woken up with symptoms during the night or earlier in the morning, just once. That's not twice, just once. That's a flare-up. So then you would instigate the flare-up section, and doctor might then change what you're doing with your medications, and they would have instructions here for you. And if they're not being very particular about what they're writing here, then you can ask questions. Well, what would I do in that section, doctor? You know, when would I come and see you, doctor? How quickly would you like me to come and see you, doctor? Would you prefer I just go straight to hospital, doctor? Then there's the severe section. Once again, now we've got, you know, my reliever medication is not lasting as long. You know, I'm not feeling particularly well. They might add in some extra medications here for you. They might put some tablet medications here for you. If your reliever medication is not lasting, then as per Asthma First Aid, you should be calling 000, but if you can't, you need to be seeing a doctor that day, but you should be calling 000 as per Asthma First Aid. And then in any kind of emergency where you can't breathe or your reliever medication is not working, then you need to call 000. Keep using your reliever medication until the ambulance arrives. But that's how you use a written asthma action plan. Now, with these dual purpose reliever medications, they do have maximum doses during the day and in, you know, at one time as well. So if you are prescribed them after you've had a talk to doctor, then it is important to make sure you discuss with doctor what the maximum doses are. So it is important to still have a blue reliever puffer in the drawer, because there is maximum doses at the end of like a 24-hour period and at the end of a at one time. Sorry, I'm not articulating that very well. I do apologise. So usually when you're taking the particular medication, you'll have, depending on the device, so there's a couple of different devices. So there's, you know, puffer devices, and then there's a turbohaler device. Depending on the device, it's one inhalation or it's two inhalations. And so it's really a discussion that you've got to have with doctor as to which device you're on and how many inhalations it is. And then depending on that particular device, and then there's maximum doses for, you know, at that particular moment in time that you're taking, and then daily limits as well. So you can't have more than, you know, 12 over a, you know, a certain day, or you can't have more than 24 in a certain day. And then doctor has to write that on the written asthma action plan. So it's extremely important that you discuss that with doctor as well. Okay, so very important. And that is in our reference information as well. So we do have a brochure on this particular information, and so we've got information on the daily limits. It's also on our Asthma First Aid. So our Asthma First Aid has all of the information about not just how to take blue reliever for Asthma First Aid, but also how to take these particular medications as well. So the Duroresp and the Symbicort, and what the maximum doses are. So if you jump on our website and you download the Asthma Toolkit, not only will you get a written asthma action plan that you can print out, but you'll also then have access to the Asthma First Aid. if you jump on the phone and call one of my colleagues on the 1-800 asthma helpline, and our phone number is 1-800-278-462, then they can post you an asthma toolkit. And in the asthma toolkit, not only do you get a paper copy of the asthma first aid, so for anyone who doesn't have a printer at home with colour printing, you also get a little emergency card that you can fold up and put into your wallet. So then you've got emergency details for anybody, and you've got asthma first aid in your wallet. We've got asthma basic facts, so that was where I had all those little pictures from, and inside there's also how to recognise a flare-up. So how do I know when my asthma control is getting worse? So when I was talking about the 2 days a week, using reliever 2 days a week, I've got nighttime symptoms, that's in there. How do I know if I've got a flare-up or getting an asthma attack? Is it a mild flare-up? Is it a severe flare-up? Is it a life-threatening flare-up? That's in there as well. So that's a good brochure. Another one that's very handy when you're going to your doctor, things to ask and tell your doctor. So then you can plan out and tick off things to talk about with your doctor. And then, of course, our phone card. But we've also got a fridge magnet on asthma first aid, so which then helps your family, if they're at home with you, when you can't breathe and can't talk, they know what to do and they can help you as well. Okay, so it's very helpful to have the asthma toolkit, and then you can, as I said, you can also download the Know Your Options Mild Asthma brochure, which is in the resource page under K for Know Your Options. But there's a link in the scrolling here with all of the text. So I think that's most of the information that I've gone over for the dual purpose relievers, because we've gone over the inhaled corticosteroids and why they're important for the inflammation. We've talked about the as-needed therapy using the dual-purpose reliever. So it's used in the same way as a blue reliever. We just whip out the dual-purpose reliever instead, but we've just got to remember about how many we can use at that particular moment in time, and then the daily limits as well. And doctor will let you know, it'll be written on the script. Okay, so you have to discuss that. There will be a very, 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 very tiny cohort that still will be allowed to use blue reliever therapy alone, and that will be potentially people that don't have asthma but get exercise-induced bronchoconstriction. So they're not actually diagnosed with asthma, but they do get muscle tightness when they're exercising. It's a very, very, very difficult thing to diagnose. And they've got to go through a lot of testing, and it's only a very, very small cohort, and there may be some asthmatics whose doctors might decide to keep them on blue reliever alone, but as per the Australian Asthma Handbook and the National Asthma Council, it does state in those guidelines that the doctor has to deem that that person is absolutely at no risk of severe flare-ups or hospitalisation. So it's, they've got to be at no risk with inflammation. So it's, really tiny cohort. So we're talking about with just blue reliever alone, and then everyone else should have some form of a preventer. Now, whether that's the dual purpose reliever or a preventer morning and night, whether that's a low dose preventer morning and night, just the inhaled corticosteroid, and then the blue type relievers for that quick acting. Okay, and as I said, the way to use the dual purpose is new, but the medications themselves have been around for a long time, so safe to use. Okay, And we've gone through, you know, what to look out for the signs for asthma control. So we know what to do with regards to that. We know that we need to keep a written asthma action plan, and that's very important. And when we actually change asthma management as well, it's important to make an appointment with doctor about a month after we've changed asthma management. It's always a good idea to do that, just to sort of touch base with doctor and make sure that things are still going okay, and that you know, that change has actually changed for the better and not for the worse on our management. Okay, so don't forget to make a follow-up appointment straight away after you've seen doctor, because we're all busy and then we forget to do it. So it's important to make that appointment, and not forget to check in. Just a point also, while I've got a captive audience, is every 12 months we're supposed to have an asthma review with our doctor. And for children, every 6 months. Okay, and an asthma action plan should be reviewed for children every 6 months, though it's not really done. It's kind of, you know, but it should be done every 6 months. And for adults, it should be done every 12 months as well. The other thing, of course, if we're changing medications, even if we're not changing medications, is inhaler technique. So if doctor puts you on something that you have never used before, then you make sure you know how to use it properly. So there's device videos on our website, and there is if you go onto a puffer and spacer, we've got a very cool little animation as well, so get that out. And but we've got all the device techniques for all the other ones as well, regardless if you're using this particular therapy or something else. Doesn't matter what you're on. And it's very important that someone checks it face to face. We can check it over the phone to make it, you know, sound that it's okay, and we can check through that you're doing it correctly, but we can't see what you're doing. You know, and if you're holding fingers over a vent and therefore not getting the right turbulence through the machine, you know, the device correctly, therefore you're not getting the right airflow, you're not actually getting the right dose into your lungs, and that can affect asthma control. Say you're taking it correctly, you're taking it morning and night, you're doing all the right things, you know, and you're going, I'm doing it, doctor. But it's that little mistake that makes a huge difference. So it's really important to get your device technique checked as well. Okay, so all of these little things matter. It's not as simple as just popping a pill and having it absorb in your tummy. There's device technique involved in all of these things. So yeah, so I think that's probably the end of my little spiel. So I might go to the questions. So I'm just going to scroll, if I can scroll and go back up to the top. J. Thanks, Jay. As I said, Kylie, yep, I agree. What's the normal dosage for the dual purpose reliever, Mandy? It depends which one you're on. Are you still there, Mandy? Let me just scroll up. So, for Duroresp, Spiromax, or Symbicort Turbohaler 206 is 1 inhalation usually. So if I go from asthma first aid, because that's where you'll be using it generally, probably should have my glasses on, that would help. Yes, so 1 inhalation for the Duroresp Spiromax or the Turbohaler 206. And if it's the Symbicort Rapihala 103, it is 2 puffs of the Symbicort Rapihala through a spacer. The Rapihala is like a puffer, and the Durarest Spiramax and the Symbicort Turbohaler are not devices to be used with a spacer. They're different. Mandy, the doctors will have been sent information out with regards to the new guidelines. Whether your doctor is completely up to date with all of them, unsure. I can't answer that because I don't know your doctor. But that's where, if you download the information about Know Your Options and talk about the asthma handbook, and if you can write down, if you're still there, budesonide and formoterol, because that's how he will find it in the, well, he should be able to find it by Symbicort and Durarest as well, actually, in the handbook. So, but the technical names is budesonide and formoterol. But if you do a Google search for Symbicort or Durarest, you will find those drug names. And that's how they will find that. Amanda. Being that you're on Spiriva, Amanda, that's an add-on therapy. So to asthma management, so you'd need to have a bit of a talk to your doctor. I think that would be the best thing. And need to have a discussion, Amanda, about being on Atrovent and Spiriva as well. They're a very similar drug on a similar pathway. Kylie, what age are you saying children for 6 monthly reviews? All children. All of them. Amanda, you find that you use your puffers more in the winter months. So you would be someone that would need to talk to your doctor as to whether or not you'd need to step up treatment over the winter months and then step down when you are not having as many symptoms in other months. Kylie, did I answer all your questions? Amanda, do you have any other questions there? Because Amanda, you could talk to your doctor about stepping up treatment during the winter months. Yeah, Mandy, did I answer all your questions okay too? Amanda, you could step up all your treatment over the winter months so that you're well, like really well controlled over the winter when you're you know, when you're really needing it, because obviously that's a particularly trigger heavy time for you. And then when you experience good control for a couple of months, then talk to your doctor about stepping back down. So you could have like a winter summer type regime, maybe not regimen. We don't have regimes in this country. How old's your boy, Chanel? 7. Okay. So stepping up treatment, like exactly what I was just saying, stepping up treatment before winter hits is really important. So it takes a preventer can take 4, 6, 8, 12 weeks to hit maximal treatment. It's not quick, so we talked about, that the reliever medications are quick. They work within 3, 4 sort of minutes. The preventers can take weeks to kick in. So they're working over time, but to see their absolute maximal benefit in your system or in your child's system can take weeks. So you'll see an improvement over that time, but you really want to start winter treatment sort of 6 weeks before winter hits, before they normally start getting colds and things like that. So if he's normally using Flixitide morning and night, then it would be important to talk to doctor about a better winter plan. So does he need to increase his Flixitide usage morning and night before, 6 weeks before winter hits, and have a higher Flixitide usage over winter to better protect him over the winter period? So he steps up over winter, weans down over the warmer months, but never comes off it. Does that make sense? So the whole idea of preventer treatment, so we're kind of really going off spec here a bit, but the whole idea of preventer treatments is you use as much therapy as you can to treat the symptoms, but you don't want to use too much therapy, yeah? So we push it, but then we kind of pull it back to where the symptoms are, and then we pull it down when the symptoms, peter out. Flixitide Junior, $50 micrograms. Just curious if anybody's got any dual purpose questions out there. Have any of my team got any dual purpose questions out there? If they feel I haven't answered anything that they would like me to answer. Amanda, as I said, Atrovent and Spiriva are on the same spectrum of drugs. I cannot give you any medical advice. All I can give you is information, education and support. And my support right now would be to discuss your medication with your doctor. Or it would be a very good idea if you could call into the helpline and discuss your asthma management with one of the asthma educators, either this afternoon or tomorrow morning. Okay, Chanel, if he's on 125 micrograms, I have the same support for you as well. It would be a good idea to have a talk to one of the asthma educators on the phone about your child's asthma management over winter, and to do that well and truly before winter, so that you've got a plan in place. Yeah, so it's not the junior, it's Flexitide, normal dosing. Yep, so that's okay. That's perfectly fine what he's on. He's on a good preventer. Doctor's doing well. But it would be good to actually have a talk over the phone with one of the educators, because this is on Facebook, so I don't want to go into, you know, discussing your son on Facebook with a live audience. Amanda, I can understand why they put you on Spiriva. Spiriva is an awesome medication, but sometimes if they're not aware that you're already on Atrovent as well, then we can accidentally get a double up. Yeah, wonderful, Chanel. So if you got our number there, 1-800-278-462. Just at your, you know, next convenience. They're really great educators and they'll go through everything with you. Yeah, Amanda, yeah, Ventolin is a good rescue one. And Atrovent's fantastic as well. But Spiriva is really similar to Atrovent. It works. So Atrovent and Spiriva. Spiriva's a long-acting version, sort of, as Atrovent. Atrovent's a short-acting and Spiriva's long-acting. So they're actually the same kind of medication. So you're kind of getting like the same thing, like too much of a good thing. It's kind of one or the other. So a medication review. But once again, we're talking in a live environment right here. So if you call in on the helpline, then asthma educators can have a discussion with you about your health needs one-on-one in a private discussion. Oh, no worries, Chanel. Lovely talking to you. Has anyone else got any other questions? If you don't, then I might wrap up there. But if anybody does have any questions about the dual purpose reliever, then call in on the helpline, because we're more than happy to go through the different treatment options for mild asthma and for all the other types. Oh, no worries, Amanda, that's okay. I just don't want to go through your health stuff in front of everybody else. You know, if you call in, then the girls can help you. Yeah, so call in on, so everybody, if you've got any questions about the dual purpose reliever, or any of your friends or family, and you know that they take blue reliever and, you know, suck it like lollies, or you know that even they just use it, you know, just every now and again. Your mum is allergic to Atrovent. Okay, that's okay. Is she okay with Ventolin or Asthma or Bricanol? If she's a mild asthma, she might be okay with this dual purpose reliever, because they're not the same kind of medication at all. Atrovent's a completely different medication. So, sorry, where was I? If you have any family members, I'm sorry, if you have any family members or you have any friends that you're like, I was listening to Gemma and you're taking an awful lot of that blue reliever, or I've heard of a new way of using blue reliever, you know, of using medications, and I now know that there's inflammation and, you know, we should be treating inflammation because the global people say we should be treating inflammation. And, you know, the Australian handbook says the the Australian Asthma Handbook says we should be treating inflammation, and the National Asthma Council said we should, and Asthma Australia and the Senior Asthma Educator says we should be treating inflammation, then tell them that there is a new treatment out there, and it's just as easy to carry around one puffer. We're just swapping out one puffer for another puffer, but it's just managing asthma so much better, and it's far more protective, and you know, that's it can decrease hospitalizations and decrease severity of flare-ups in, you know, the long, if we're looking at it, you know, from a longitudinal, we're looking at it in the long term. So you know, we're protecting the asthma community, and you know, that's what Asthma Australia is all about. We're trying to protect everybody, you know, and protect the people with asthma. So you know, so if you see anybody in your families, then tell them about it. Share the information, get it out there. All right, so, you know, share this post later. If you can share it throughout your groups, you know, your grapevines, you know, your suburb grapevines, then do so. That would be absolutely fantastic, because the more we get the word out there, the more we get the word, you know, dual purpose reliever out there, then you know, then it'll start taking off. So that'll be absolutely fantastic. Okay. All right, well, it was lovely talking to you all today, and you know, who knows, if you call in on Thursday, you might get to talk to me on the phone. All right then, okay. See you. Bye.